Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Donna White. Donna is the creator of the Hormone Makeover and the Bioidentical Hormone Replacement Training Academy, or BHRT Training Academy. Donna has a very interesting story and struggled with her own severe hormone problems in her early 30s, which started her voracious study of bioidentical hormone replacement therapy. She wanted to make sure that other women did not have to suffer like she did. She went from being a hormonal train wreck to growing 4 practices, publishing a book, writing several ebooks, a training manual for providers, appearing on numerous radio and TV shows, filming multiple educational videos, podcasts, and blogging, and has become an internationally recognized speaker for medical conferences, business organizations, and women's groups in the topic of bioidentical hormone replacement therapy. Donna is one of the best educators in the fields of wellness and hormone replacement therapy available today. Based on her over 20 years of experience, she has an uncanny ability to effectively communicate to both physicians and the lay public. After my interview with her, I knew that many of our audience would want to take her online training course, and she has generously offered a discount code BHRTSB at her website, BHRTtrainingacademy.com. That is the code BHRTSB at her website, BHRTtrainingacademy.com, to take her courses. I hope you enjoy this episode as much as I enjoyed my conversation with Miss Donna White. All right, I'm here with Donna White, who is the founder of the BHRT Training Academy and the author of Hormone Makeover. She published that around 2010 and has a second edition coming out. I'm really happy that you're here with us today, Donna, because you have such an experience in bioidentical hormone replacement therapy, and it's something that touches everyone's lives. Even if you're not practicing specifically in hormone management, you need to have an awareness and acknowledge some of these things so you can make the proper referrals. I think your story is fantastic, how you got here, your journey. So would you mind sharing that a little bit with the audience?
Absolutely. And thank you so much for letting me participate and be in front of your fabulous group of well-informed practitioners and healthcare providers. So here's my story. I am a recovering hormone train wreck. That's right. 30 years ago, I had a terrible case of PMS. I just turned 60, and in my early 30s, I realized once a month, every month, I became so irritable and angry and agitated. I wanted to rip everybody's head off. My skin was breaking out, and I was beyond puberty at that point. Had cramps, all headaches, premenstrual headaches. And thank God I realized that, hey, this is hormones. But I also knew I don't want to be on the pill, a synthetic hormone. I don't want an anti-anxiety medication or have to be on, pain meds for headaches. Something's wrong here. Let's fix the root cause here of what's going on. Thus began my deep dive and study into hormones, hormone imbalance, what's going wrong, what my options are. And therefore, I have personally been on bioidentical hormones for 30 years. Yes, I am the poster child. I have been on them that long. I don't know if that makes me vintage or antique or whatever, but I've been around the block a few times.
I guess vintage is if you're a car or a human, right?
Okay.
But yeah, so when you got started with this journey, did you have pushback or basically just ignorance from some of the physicians that you were wanting to help you?
Actually, that's a great question. Back then, 30 years ago, there were very few medical providers that knew this, but there were a few. So that's when I started going to conferences, looking at the literature, learning this process. And mainly some of the things that I needed at that time were over the counter. Since then, I've gone through menopause and thyroid issues and yes, needed some prescriptions and so forth. But, that all took care of itself along the way. But way back 30 years ago, there just weren't that many practitioners that were well trained. So I got called upon to speak at medical conferences all over the place, and supplement companies hired me to, consult with them about hormones, and so did pharmacists, help we want our doctors to learn how, our healthcare practitioners to learn how to prescribe these things. And the more I learned, the more I wanted to teach women and practitioners. I was speaking one day at a conference, and a cardiologist, an integrative cardiologist, happened to be there. And he said, "You know what? You know more about hormones than anybody I've ever met." Granted, this was 30 years ago, to be fair. And he said, "Will you come to my office and start seeing patients?" And what was my answer? Yes, sir, absolutely. So hence I learned, how to, implement this strategy, this modality within medical practices. And the more I learned, being a teacher at heart, the more I realized, hey, practitioners really want to learn this. So that's why I dedicated my life and time to help educating practitioners and women and men. There's
right.
just that we need to talk about. So that's what I do. I teach BHRT.
Well, I think that, I think you touched on something, that I want to get into that, there's, I think, still some misunderstanding between bioidentical and non-bioidentical hormones. Can you give us a little bit of insight on that so that we have that foundation to proceed through the conversation that we're going to have?
Thank you for bringing that up. That is so important, Dr. Eric, because I call this the hormone confusion. Patients are confused about hormones, and sadly, many practitioners are as well. Not your listeners, but many are. So yes, let's get this nomenclature out of the way. So what are bioidentical hormones? Bioidentical hormones is not really an official recognized medical term. Maybe I'll just call it slang, but it's called bioidentical hormone replacement therapy because it all comes down to one thing. That's the molecular structure of the hormone. Okay, so what am I saying here? Biologically identical, or bioidentical, is how the word was derived. Biologically identical hormone replacement therapy simply means using the same hormones that our bodies make or are supposed to be making, exactly the same as the endogenously produced hormone. So let's go back one second.
So let me interject real quick so I make sure that I'm clear. The bioidentical is a molecular equivalent, albeit manufactured, to the endogenous hormones that we manufacture.
Yes, an exact match. And
okay.
What we learned way back in Chemistry 101 is that the shape of the molecule determines the actions and effects or the properties of that molecule, right?
Right.
Why does it matter if it's the hormone is derived from horse estrogen, for example, such as perimenopause, or a synthetic or like a phenyl estradiol, or some sort of synthetic progestin? Why does that matter if it has the same molecular shape or a little bit different molecular shape? It matters a lot. And I'll sum it down to one word: side effects or adverse risk associated. So if we're talking about the shape of the molecule, let's think about how hormones deliver their messages. Because what are hormones? They're chemical messengers, right? They say, oh, have a good libido. Oh, build an endometrial lining. Oh, balance blood sugar. Do this, do all these things. So their messages and how they deliver that message, one of the primary ways is that they enter into a hormone receptor. Just like the key enters into a lock. And if you think about that analogy, I didn't coin that, but it as a key fits perfectly into a lock, what do you get? You get to open the lock. You get to do what you're supposed to do. Have you ever forced the wrong key into a lock or tried to? Well, I have.
Right.
Didn't very well, doesn't go in properly or goes in a little way and you can't get it out, it won't dislodge. Hormones are the same way. If they aren't the same shape, it's not the human identical, biologically identical estrogen or insulin or testosterone or melatonin, what have you. If it's not that same exact molecular structure, doesn't fit in that receptor perfectly, doesn't dislodge properly, doesn't get converted into the downstream metabolites, binds too tightly to the receptor. All of these issues can and do occur if you don't use the right human identical hormone to replace what's missing. So does that clear up a little bit more what exactly bioidentical hormones are?
Yeah, I think so. I would, I have the lock and key analogy. I think that's a great analogy because I think everybody can understand that. We have an agonist, we have a receptor, and it's going to produce the effect that we ultimately want. Let's go back to the key for a second. I mean, how many times have you gone down to the hardware store and you replaced a key and it looks really pretty similar, but it might have a little bit of a burr or its cutout might be off like a fraction, and it does go into the lock, and sometimes it'll even turn the tumbler, but it doesn't do it very well. And then sometimes when you go to try to take that key out of the lock, it doesn't want to come out. It's stuck in there. And I think that's a great analogy because I think that's what you're telling me with bioidentical hormones.
Yes, absolutely. You've got it.
Yeah. Well, all right. Now that everybody kind of understands the difference between a bioidentical hormone and maybe something that was just dreamed up in one of the big pharma labs, let's get into some of the myth and the dogma. I think one of the premises that I wanted to try to hit when I developed this podcast was to try to restore or to destroy some ridiculous dogma along the way. And there's a lot of dogma in medicine, just like there is in any other profession. And I think there's a lot of dogma here that we can get into just on testosterone and estrogen replacement. But before we get to that, to try to destroy this, what I would consider harmful dogma, actually, I think a lot of people have been irreparably and maybe not irreparably harmed by this. And but regardless, let's talk about the big beast in the room, and that's acceleration of cancer with hormones, because that seems to be this ubiquitous topic that's always brought up when you talk about hormones.
Yes, there is that. But sometimes even before you get there, Dr. Barrett, we'll hear a little pushback. Oh, there's no research on bioidentical hormones. That's a myth. There's decades of research. Some of the early research on bioidentical hormones came out as early as 1976. And we have many, 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 many current studies. And I'll take that one step further. We have many studies that compare bioidentical hormones to non-bioidentical hormones. And I'll just give you the insight on that real quick here. Every study that's ever compared the two bioidentical hormones always demonstrate more favorable and more effective results. So that is a myth. We're clearing that up. Is there any research to support the use of bioidentical? Yes, yes, yes. So and that leads us into what you have alluded to and pointed out is, okay, we were sort of misled by some research that came out in the early 2000s that indicated, hormones, HRT, cause breast cancer. There's also been some misindicating or suggesting that TRT, testosterone replacement therapy in men, can increase the risk for prostate cancer. So I am so glad you're giving me the stage to dispel some of that. So which one would you like to talk about first?
Well, let's go into the Women's Health Initiative of 2002, because I think that is really illustrative of misidentifying some of your own data points or attributing things. And I think it reflected a significant amount of confirmational bias in that. So let's talk about the WHI 2002 study.
Okay, let's do. First of all, anytime, what contributes to part of the confusion is when the media or even some conclusions in the journals come out, they'll say, oh, this hormone caused cancer. Well, which hormone are you talking about? Are you talking about biologic? Are you talking about, endogenous estradiol? Or are you talking about pure estrogen, conjugated equine estrogen? Are you talking about synthetic progestin? Are you talking about biologically identical? You see why there's so much confusion?
Right.
There's just not the proper explanation of what the studies were done on. Okay, so back to this famous or infamous WHI, Women's Health Initiative. I remember where I was. I was at a hormone conference the day that study came out. Hormone geek, sorry. So that study came out in 2001. It was the Women's Health Initiative. And prior to that, HRT had been used for decades in this country. By the way, bioidentical hormone replacement therapy has been used for 70 years in Europe. 70 years. Some countries even, give it like, our Medicare, they give it, to aging people. But anyways, I digress. Back to the WHI. What was that study done on? That study was done on medroxyprogestin acetate, horrific hormone. Never used that. So that is a synthetic, non-bioidentical form of progesterone, and it was done on conjugated equine estrogen oral. There's a big difference between oral and transdermal hormones. We can talk about that later if you want to. So that study was done on conjugated equine estrogen and progestin. And they came to a lot of early conclusions. They saw increased risk of breast cancer, heart disease, a lot of things, and it scared a lot of people. So they stopped the study. But some of the problems, and we don't have to go so deep into the problems because I'd like to get to the good news and what they found when they the reanalysis 19 years later. But practitioners were scared. They stopped, they took yanked their women off of hormones. They were afraid. And, what we know is that medroxyprogestin acetate is what causes breast cancer, increased risk. What we also know is that real progesterone helps prevent breast cancer. So when you compare the two, the synthetic progestin and the endogenous progesterone, big difference. In fact, as we're leading into this breast cancer thing, what we learned about progesterone way back in 1981, I forget which study, Johns Hopkins published a study, 1981, and they found that half of all breast cancer could be prevented by having a normal level of progesterone. Since then,
wow.
Many studies have come out helping us understand, verifying that, helping us understand how protective progesterone is of the breast tissue. Well, let's go back to estrogen. Again,
right.
We know estrogen, one of the things it does is a proliferatory hormone. It causes tissue to grow and multiply, in like the endometrium and the breast tissue. It's supposed to. That's the whole basis of reproduction, right? Build that endometrial lining, get the breast tissue ready because there might be a baby coming that needs nourishment. So, but what do we know about giving women estrogen? Okay. what we know when they went in and reanalyzed this study, the Women's Health Initiative that caused a whole lot of problems. In fact, let's see, the 19-year reanalysis was done by, get this, 12 prestigious cancer centers. They're the ones that went through this and walked through it. What they found is that actually estrogen has a 23% conveys a 23% reduction in the risk of getting breast cancer for the next 20 years. That was horse estrogen. I do not recommend that at all.
Right.
We have real bioidentical estrogen, but 23% reduction in the risk of breast cancer for the next 20 years, even if they had only been on it a short while. And what's more, listen to this. If they had, the longer they had been on estrogen, the better their results. But listen, if they got breast cancer, if they contracted it while they were on estrogen, they had a 44% less risk of dying from it. Can you believe the confusion that all of that misinformation caused?
Yeah, you had a 20-year gap where people weren't treated appropriately because you had a study that compared a bastardized form of the hormone that they were supposedly supposed to be studying, but really in reality, they weren't. I mean, I could imagine a study that says, all right, aspirin's bad for you because we studied ibuprofen for 10 years. Right? I mean, that makes no sense.
You're right. But you know what else came out last year? Okay, so what we're talking about, this reanalysis that came out last year, you know what else came out last year about estrogen and breast cancer? This study was done by Yale, that little place up there up north somewhere.
I heard of them.
You've heard of it, okay. Yeah. Well, they looked at 7 million women over 12 years. And what they looked at was, they were looking at estrogen, ERT, and they compared different types of hormones, different types of routes of administration, because, you can use hormones orally, transdermally, and so forth. And they looked at different strengths. And what they found, you got to hear this, that estrogen replacement therapy statistically reduced the risk of 5 different cancers, 33%, including breast cancer, 33% less risk of breast cancer, 33% less risk of ovarian, lung, and colorectal cancer. Less risk if you're taking estrogen. Women need to know. Thank you so much for letting me talk about this, Dr. Bear. It's so important.
Well, I think, too, the thing that isn't even it's starting to be talked about a lot more. Aside from breast cancer, we know that estrogen is cardioprotective if administered properly. We also know, with the additional studies that are coming in, from a neurocognitive standpoint, Alzheimer's disease, this could be critical because if you look at the stats right now, it's, I think, 3 to 4 to 1 female to male incidence of neurocognitive disorders, specifically Alzheimer's. I'm not sure exactly that's the right ratio, but it's close to that. Point is, there's something going on with estrogen and these pathophysiological processes, and that's really important. And here you go, you've got this study that comes out in the early 2000s, and it treats a couple of decades of less than ideal, less than optimal treatment for these women.
Thank you for bringing that up. Estrogen is cardioprotective. It does protect the brain, the bones, and that's not new information. There are 1 or 2 studies. There's decades of studies verifying that.
So let's go to the male aspect, because, I was in the camp where I believed that, if you supplemented after, can we call it menopause? Where your testosterone starts to drop. I think the peak is early 20s, and then from then on it's downhill. But long story short, I was in the camp where I thought testosterone supplementation could actually increase your risks of developing prostate cancer. And I think when you dig into that literature, it's very interesting. We were talking a little bit before we started recording, but what's your comments on the testosterone replacement? Because I'm sure there's a lot of men still running around thinking, well, hell, I'd like to feel better and take some supplementation, but I don't want to, my father may have had prostate cancer, or there's a family history. I don't want to put myself into that category. So this false belief leads me into not optimizing my treatment.
Yes, you are so right. Again, another myth that it's important that we address, not with your opinion or my opinion, but with data. That's right. What we always want to come back to. What does the data really say? So as we go into that, I'll make one more point. I was just saying that estrogen helps prevent the risk of breast cancer, and progesterone, we talked about that. But testosterone now in women, the use of testosterone, because we need a little bit, is very protective. So now with men, okay, so you're so right. Androgen deficiency, testosterone deficiency is very common. In fact, 1 in 4 men over the age of 40 have low testosterone. And just because your libido might be normal does not necessarily mean your testosterone is fine. Because you can have that desire and still have low testosterone. So gentlemen, get your testosterone checked. So what happens by the age 60 with a 1 to 1.5% decline in testosterone every year, just like you said, Dr. Barrett, over the age of 20, by the time a man reaches 60, his testosterone production can be down as much as down to 40% of what he was making in his prime, in his early 20s. And by the way, just for the sake of logic, when is testosterone highest in young men? College years, right?
Right.
It's peaking. Is that when we're seeing prostate cancer? Do we see, a rampant prostate cancer in these college men?
No,
not at all. Okay. Right. Back to the data. Harvard, another school you listeners might have heard of, they went and reviewed many, many different studies, and they just could not find any connection between the use of testosterone replacement and increased risk of prostate cancer. One more step, I'll take this one step further. Other data shows that men with low testosterone have an increased or a higher percentage of prostate positive biopsies. So this might be protective, not causative.
Right. Well, I think there's also a cardioprotective aspect of testosterone as well.
Where the greatest concentration of testosterone receptors anywhere in the body? It's not the genitals. Where do you think it is?
Well, based on how you preface that question, I'm going to say maybe the myocardium.
Heart. Yes.
Right.
Men and women. And
interesting.
We have receptors all throughout the body, but the greatest concentration of T receptors is the heart. And so, yes, it's cardioprotective. What we know about testosterone for men is, yes, it helps with insulin resistance. It's cardioprotective. It's cognitive. It helps us, think of what does testosterone do? It's an anabolic hormone. Build muscle, build that immune system, and men and women need it.
Right. So if you go back, and I dug back into the literature as far as the giant myth of testosterone causing prostate cancer, and you can trace it back to a study that came out in Cancer Research, 1941, Huggins and Hodges. And to show you what kind of a crap study this was, it basically was based on data from one patient. One. All right. And that data was based erroneously on just acid phosphatase levels, which I don't want to get into the biochemistry here. But again, you have to ask, is that a great proxy to make this declaration in one patient, by the way, that has affected generations of men? And you have to blame the media a little bit on this, because they'll seize on, a seriously flawed study like this, and then the layperson doesn't know. They just hear it on the news that night that, oh man, if you supplement with this, you're gonna, and then, it just drives me crazy when they look at, relative risks versus absolute risks. And, that's another discussion sometime. I should get a statistician on here.
All of the sponsors of this podcast are listed on the website at potofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000, but you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been. So anyhow, let's talk about bioavailability and how. Well, first, let's talk about how to measure these hormone levels in the patients. So, is it best? What's the best way to test them? That's probably the easiest way to go.
Well, it's a little bit of an answer, so thank you for giving me time to, allowing me the platform to explain that. You can test hormones in basically 4 different ways: serum, capillary blood spot, which is whole blood, so it is different from serum, salivary testing, and then 24-hour urine or dry urine. So we have those 4 ways. And as we're talking about this hormone testing thing, let's preface it a little bit, Dr. Barrett. When I'm talking about hormones, I really like to make sure that patients, providers understand we are not just talking about estrogen, progesterone, and testosterone.
Right.
We're talking about insulin, thyroid, adrenal hormones, DHEA. Right. And all of these hormones interact, interfere, work together. So a really savvy, well-trained practitioner is going to look at all of these hormones. So some hormones cannot be tested in saliva, and some can, and some can be checked. The rest we can check in serum or dry urine or capillary blood spot or so forth. So how do you know which test?
Right.
I guess I would say that, serum labs are okay for checking pretty much everything. And when I say checking everything, we want fasting insulin, hemoglobin A1C, glucose when we're looking at that, DHEA-S, the sulfated form when we're looking at adrenals, then for thyroid, TSH, but that's not the end all. We have to look at free T3, free T4, TPO, reverse T3, and then we look at estradiol, progesterone, and testosterone. It's really okay to do that in serum, but here's the kicker: cortisol.
Right.
Cortisol, as you were talking about, how hormones have to dock like a key fits perfectly into that receptor. If cortisol is elevated from stress, it blocks all of the other hormones from getting where they need to be. Insulin resistance to a certain degree. So if our cortisol is high, it messes up all the rest of the hormones. How many people have stress in their life and potentially have cortisol imbalance? Most all of us. I don't have to deal with mine all the time. So what I'm trying to say here is that cortisol has to be tested, but it can't be tested in serum. I know you can order an AM cortisol in serum, but that's not the story. The story is we want to know a diurnal pattern for cortisol. We want to see it morning, noon, evening, and night, because think about cortisol.
Right. There's a circadian rhythm. It's much like oral glucose tolerance testing. You want to test right after you give that bolus of glucose. I get that. So what's the best way to test for cortisol then? Saliva?
Testing. Dried urine or salivary testing.
Okay.
And think about it, that's convenient to do at home. Who wants to go to the lab four times a day?
Right.
And what happens if somebody comes with you at a needle? Some people are cortisol,
Right. Yeah, there's a huge amount of trypanophobia, fear of needles out there. So that's going to drive your cortisol way up. Another way to measure cortisol by proxy is with continuous glucose monitoring. And people don't really think about that, but what does cortisol do? One of its functions is to get some glucose into the bloodstream because you're running away from the animal that wants to eat you, right? And so you can be in a fasting state and stress somebody, and you'll see their glucose spike, like if they're on a Dexcom G6 or something like that. But that doesn't give you a number. It gives you a little bit of a proxy of what cortisol does. So I want to go back to one thing that you just said about stress. And when we look at biohacking, we talk about, and my listeners are probably sick of me talking about the 4 pillars, food, sleep, exercise, and then spirituality, mindfulness, however, but I would put that into the managing stress category or stress reduction pillar. But what you just said is really, I think, a great way to conceptualize how stress is very detrimental for you from the standpoint that you just said it acts as an agonist for all of these receptors for these other hormones that we need properly. So if you have someone that's just constantly stressed, think about all of what you just said. I mean, that's going to affect insulin, thyroid, right? The sex hormones. The whole gamut.
All of that. And Dr. Barrett, people are confused. There occasionally will be a person who says, "Oh, I'm retired. I don't have that much stress in my life." It's not just emotional stress or being overly busy. It is those things. It's also underlying stressors like toxins, like food sensitivities, like what you just said, blood sugar imbalance, because maybe somebody's eating way too many carbs and then that's spiking, their cortisol and so forth. So it's these other things. It's toxins in the environment. It's emotional. I mean, you're kind of saying, it's perceived stress. So stress is a lot. It's lack of sleep. The other pillar.
Right.
So many factors that stress the body, and how does the body respond? By cranking out. We have to have some cortisol, right?
Right.
But taking out too much or at inappropriate times causes problems.
Right.
So, up in the morning, we're tired, or too much cortisol at night, we're exhausted. But what happens? Our brain just goes on, being wired and can't stop thinking. So it's very important to measure and address cortisol to get hormones into balance. We have to look at all of those hormones and absolutely cannot neglect to check cortisol, because initially it does rise, but if the stressors go on long enough, then what happens? We get a fluctuation of cortisol. It's too high at sometimes, too low at sometimes, and then it can just be low all of the time. And those poor patients are exhausted. Completely exhausted. And one of the worst things that cortisol causes, here's an incentive to talk your patients into having their cortisol tested, because you have to pay out of pocket for that. It's not that much. But anyways, cortisol, there's a lot of cortisol receptors in the abdomen, 4 times the number of cortisol receptors anywhere else. And what happens when cortisol is high? Abdominal weight gain.
Interesting. So it's working on the fat cell to deposit more fat in there from an energy preservation standpoint. Is that a protective mechanism, maybe?
I can't say that I really know. I just know that your efforts to address weight, lose weight or maintain weight, it just totally is totally impaired by high cortisol. But we talk about weight and hormones. I can tell you which hormone causes weight gain.
Okay. And I'm going to guess that you already just talked about it.
Here's the type of hormone imbalance that causes weight gain. High estrogen, low estrogen. Women gain about 20 pounds at menopause. Shouldn't be. Okay, so high estrogen, low estrogen causes weight gain. Excess progesterone, low progesterone. High testosterone is associated with weight gain. Low testosterone. Elevated high cortisol, low cortisol. Every last one.
So what you're just telling me is we want to be right in the optimal therapeutic range.
Yes.
Okay. Very good. All right. So to sum that up, which I think is so clinically pertinent for people, we want to test some hormones, serum plasma. We want to test cortisol with, one of the other methods, maybe salivary testing and that type of thing on a basically, let's call it a circadian basis, for lack of a better way of putting it. All right. So now that we've got that, let's talk about, you said you had a 7-question item checklist that you could ask folks and kind of dial into their hormone situation.
So let's do a free test now that we're talking about hormone.
Okay.
And I'm glad that you're letting me have the opportunity to do this, because a lot of people, there are some symptoms that people don't connect to hormone problems.
Okay.
And I'm be able to recognize these in your patients. So, maybe this is, maybe you want to start offering bioidentical hormones, or maybe you want to just be in the know because you want to, be a good resource to your patient and refer them out, because there are some practices out there not necessarily doing hormone therapy as they should. So anyways, back to the quiz. Okay. So here's 7 questions. Number 1, fatigue. Okay, so the fatigue that's all day or in the middle of the afternoon when you want to be on top of your game. You'd rather be on top of your desk taking a nap. So fatigue there's many causes of fatigue, but hormone imbalance, any of these 7 hormones we're talking about, can directly impact your energy level. Okay. So that's number 2 is sleep. Near and dear to your heart. An imbalance in these hormones can cause trouble going to sleep and staying asleep. So if you have, exhausted at the end of the day and you lay down and you're wired and tired and thinking of all these things you could have, should have done, need to do tomorrow, that can be a hormone-related issue. We know we need normal cortisol and estrogen, progesterone, all these hormones for good, sound sleep. The other component of sleep is sleep disturbances, waking up at 3, 4 o'clock, 5 o'clock, can't go back to sleep. Think hormones, okay? Balance for sleep. So we've got fatigue, we've got sleep. Number 3, foggy thinking. Can't remember what you went to the pantry for. Read a paragraph. What did I just read? I can't tell you, having worked in a number of different practices, with one-on-one with patients, they're like, I think I have Alzheimer's. Let's check your hormones. If those hormones optimize, good diet, good supplementation, all your 4 pillars, you can think again, and long-term protection. So we've got fatigue, sleep, foggy thinking. Then there's mood. Number 4 is mood, whether that's anxiety, mood swings, depression, or low mood. Think possibly hormones. Okay, because we need hormones to do what? Help synthesize neurotransmitters, for one thing, just extremely anti-anxiety. So think about mood as being connected to hormone issues. Then number 5 is kind of the normal symptoms. Women know they'll think hormones if they're having menopausal symptoms like vaginal dryness or hot flashes or PMS or, low T androgen symptoms like, some of us men don't know, but loss of muscle tone, stamina, loss of morning erection. So, the normal or, the common andropause or menopause or perimenopausal symptoms. That's number 5. Number 6 is aging or wrinkling too rapidly. We need hormones for collagen production. In fact, even a study has come out showing that women with low estrogen levels with their estrogen levels are low. They look 7 years older than women with normal estrogen. Well, I don't mind getting older, but looking and feeling older, I don't want to do that unless I absolutely have to. I'm going to fight that one. So
right.
It's rapid wrinkling and aging, thinning of the skin. Like you think of like little old ladies, their skin can be so thin. We gotta have good, strong hormones for maintaining the integrity of our skin and our joints and so forth. Lastly, last 7 question in this 7-question hormone quiz is weight. And we kind of already talked about that. So if your hormones are out of balance, it can be nearly impossible to lose weight or to maintain weight. And it can be so frustrating because, a lot of people are very savvy, like your listeners, and they know to eat right. They know they need to exercise, but to put in all of that effort and to not get any results or the results you feel like you should be getting, that's very discouraging. And no wonder sometimes people give up. So you really need to have your hormones assessed properly and to see if that's the problem. So that's my 7 common symptoms. Now, there's a whole lot more symptoms. Obviously, I've got a symptom checklist we can certainly share with your providers. But just look at how common those 7 symptoms are. Who doesn't have 1 or 2 of those?
Right. Well, I'm going to share a little clinical story with you that just happened to me recently. I have a patient that is post-decompression. She had some nerve entrapment, young 30s, and we did everything because, from a testing standpoint, and in fact, I referred her to an endocrinologist because everything was just off the charts bad. And she had a wound dehiscence. And we had left the stitches in for 3 weeks, a small incision, nothing really super exciting. But now that you just mentioned that about collagen, because when I saw this, I in my mind, I'm going, wait, we left these stitches in for a long time and she's young, relatively healthy, but not. When you look at all of the metabolic biomarkers, she's really not great. But now it draws a little bit of focus in from the standpoint, well, yeah, maybe she wasn't just able to make the collagen she needed to repair this surgical wound. So thank you for sharing that. I mean, we see these things, not specifically that, but we see these things all the time clinically. And sometimes it takes a little bit of something, you got to jog our memory or give us some little tool like this to say, oh, well, yeah, that could factor into, why I'm seeing what I'm seeing. So that was great. So,
in your practices, because you know how many women enter menopause every year? 1 million. And women live a third of their life in menopause. And 70 to 80% of women, complain of PMS. Recently, Dr. Bear, I just heard a statistic that by the year 2030, the number of women in menopause and perimenopause is going to be 1.2 billion. That's
wow.
A lot of hormonal women. You should be afraid. Be very
Yeah. Well, I'm not going to make any comment on that. So, this has been really a great, I think I'm going to have to call this a primer because I think we're going to have to, if you're willing to in the future, come back and we'll talk about some of the specific nuances and everything. This is so important. And I think sometimes these things that are so important, they just are not on the radar for a lot of clinicians. And it's like, oh, that's the endocrinologist bailiwick. Well, yeah, that's true, but it's also your bailiwick if you have that wound that doesn't heal, or you have to be able to identify these things and have an understanding in order to make a proper referral and a timely referral. And so I think your information's been excellent. So you have a great training platform for people. Tell us about that so that the people who are interested listening to the show can get there and get to your training academy and get this training, because it's going to impact their practice, whether they're going to prescribe bioidentical hormones or not. It doesn't matter. It just matters that, anytime you impart knowledge, you impart power.
You are so right. And I greatly appreciate and respect that comment. Yes, I do have the BHRT Training Academy, and we specifically train medical providers. We also have pharmacists, compounding pharmacists, dietitians, nutritionists, dietitians, chiropractors that take our training because they want, it is a very in-depth training. We teach providers precisely, what I consider the four components to implementing BHRT or TRT into your practice. First of all, you have to learn the foundation. You really have to learn these studies because, providers need to be confident in what the research says, because patients have questions confused. So we go in depth on studies and what all of the hormones do. I know that you learned it back in medical school if you went to med school or nursing school or whatever, but we got to go back to it in depth and talk about how these hormones interfere and work together. And then it's very important, step 2 or component 2 is to learn how to properly assess and, assess which type of hormone balance. Yes, there's testing. There's a lot of nuances to hormone testing and, go through deep symptomology so you can recognize it. And then, I call it the next component is the application. You really need to learn all of the dosing forms. There are some training out there, some practices that, for example, only know pellet therapy. Okay. Mm-hmm. One. But not every patient wants a pellet, and not every patient is a candidate for pellet. So please don't send your patients to refer them out or just take training on just how to do pellets. You really need to learn, how to dose some oils, never oral estrogen, never oral testosterone, but you need to learn how to dose the creams. You need to learn how to, patches or vaginal forms of hormones or injectable forms. You need to learn how to do, you need all the tools in the toolbox. And you need how to implement all of those. And it's not just hormones. What are you going to do if somebody's testosterone is too high? Like in a number of women, like PCOS patients, they have too much testosterone. You can't get that up woman hormone. Or if somebody makes too much, cortisol, you need to know supplement therapy. Okay. And lifestyle and dietary changes, all of these 4 things. Hormones as indicated, bioidentical only, supplements, diet, and lifestyle to get hormones back in balance, because that's what we're looking at. We're looking for balance, okay, to get rid of symptoms, but we're also talking about helping keep the diseases associated with aging at bay, which is what we've kind of been talking about with some of these studies. So
Right. And now, now that we have some of these very good methods to look at chronological age versus biological age, this is going to plug in more for the the biohacker crowd, because we think about all of these other things, but maybe hormonal optimization is not at the top of mind, and it should be. We know that they're all, gears intermeshed in this incredible machine, and one gear's out, all of the gears are affected.
So right.
So, Donna, thank you so much. It is an honor for me to have somebody like you on the show. I learned a lot. Actually, I learned that I was quite a knucklehead when I couldn't figure out why this young patient dehissed. I thank you for that. And I want to bring you back for another episode on hormones and pain management, because I think that's a big, big topic, and nobody thinks about it.
And there's data, because I looked at some this morning about it last week. And yes, we have data on pain, the use of hormones for pain, inflammation. I mean, it's so fascinating. And by the way, if you have listeners that would like some freebies, I have a 30-minute free webinar if somebody just wants to learn a little bit. We have a symptom checklist that people could use in their office. I have a dosing guide. So I've got some freebies. You're more than welcome to share those. But our website is BHRT Training Academy.com.
I will put that in the show notes, and we'll put some of those links to, those very valuable resources. I think, once you take a little sip from the glass and you like the taste of it, then pretty soon you've tipped the whole glass and you're pouring again. And I have a feeling that's going to be with your training academy, what's going to happen, because if you have some interest and then you get some knowledge, then you have more desire to go down and, get into the weeds, so to speak, with this.
It's possible.
That's exactly right. So, Donna, thanks so much. I really appreciate it. Let's talk about hormones and pain in the near future.
Thank you so much. And thank you, everyone, for listening.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.